This lecture is going to be about the ophthalmic exam.
Just like the rest of the body, the eye has its own vital signs that need to be collected. Then there are tests that assess the function of the vision. And lastly, there's an anatomic exam of the different structures of the eye. We start from the outside, the lids, the lashes. Then we go inside to the cornea, the iris, the lens, the conjunctiva and sclera. And then further, we look inside the eyeball at the vitreous body, the retina, the optic nerve, and then we are able to see if there are any diseases in the eye. First, we'll check the vision, pressure, and pupils. Vision testing is done by comparing what the patient can see to what the average person can see standing at 20 feet or 6 meters. We have created a standardized chart of what the average person could see standing at 20 feet, 25 feet, 30 feet, 40 feet, 60 feet, 70 feet, 80 feet, 100 feet, 200 feet, 400 feet, and so on. If the person's vision is worse than that, then we ask them to count the number of fingers we hold up in front of them. If it is worse than that, then you move the hand in front of them and see if they can see motion of a hand. And if the vision is worse than that, you check if they can perceive any light or not. Distance vision is measured at 20 feet or 6 meters. You put up a chart like the one on the right, which is called a Snellen chart, and you ask them to read with one eye at a time the letters from the top going down as far as they can to the bottom. If they can see the line on the very bottom, that means their vision is 20 over 20. They can see at 20 feet what the average person can see at 20 feet. However, if they can only read the very top line, the big E, that means that your patient is seeing at 20 feet what an average person can see 200 feet away. We can also check the near vision using a card version of this chart, and that is held at arm's length, about 14 inches away. If a person cannot read letters, we can also check the vision using numbers or symbols. This is an example of two near cards using something other than letters. The one on the right uses numbers for someone who may not be able to read letters, and the one on the left is for younger children who can recognize symbols but can't read yet. Just like the body has pressure generated by pumping of the blood from the heart and the resistance of the blood vessels, the eye, which is a closed system, also has its own pressure. And if the pressure is too low or too high, that can cause problems. We measure the pressure of the eye indirectly. We cannot stick a probe inside the eye to check the pressure, so what we do is we try to apply an indenting force onto the cornea. And we see how much resistance the cornea gives as we try to push on it. That is how we measure the pressure inside the eye. The most basic way to do this is to have someone close their eye and press on it with your fingers. And after you have seen many patients, you are able to have a sense of what pressure is normal and what an eye that is very hard will feel like and an eye that is very soft will feel like. The moderate, easy way to do it is with a handheld instrument that is slightly more accurate, like the one on the right, which pushes a small little probe quickly against the cornea, so quick the patient cannot even feel it, and it measures the resistance to indentation. The most advanced method and the gold standard is called Goldmann applanation. On the right, you have someone palpating the eye to estimate what the pressure is. On the left, you see what it looks like to check pressure with Goldmann applanation. How to do this is beyond the scope of this lecture, but a round instrument like this presses on the cornea, like so, and the eye has a dye that has been placed on it, which will light up when this instrument is pressing, and a trained ophthalmologist can interpret this to check what the pressure is. The pupil exam is very important. It can help identify neurologic problems and even emergencies for which a patient might need to be sent to an emergency room. There are certain key principles to the pupil exam. Number 1, if you shine a light on a pupil, it must constrict. Number 2, if it is dark, the pupil must dilate. Number 3, the pupils must work together. If you shine a light on one pupil, the other one must constrict even if light is not being shined on it. This is called the consensual response. If the pupils are focusing on something up close, they will constrict. If they are focusing on something at a distance, they will dilate. The pupil exam is very important, and doing it correctly is also important. These are the key steps. Number one, have the subject look at a distance so that they are not constricting when looking up close. When they are looking at a distance, with the lights on, measure the pupil size. You can use a small ruler to measure this. Now, turn the room lights off, but make sure there is a source of ambient light so you can see what their pupils look like. Stand to the side with a pen light. Direct the pen light on one of the eyes, making sure that the light does not hit the other eye. Observe what is happening to the pupil that you are shining your light on. Is it constricting or not? This is the direct response to the light. Now, while you are still shining a light on that eye, look at what's happening to the other eye. Is it constricting or dilated? This is the consensual response, the response of the fellow eye. Now, repeat this process by shining a light on the second eye. Is it constricting or dilating? And while you are shining a light on the second eye, what is happening to the first eye? Is it constricting or dilating? This is a diagram that will better help illustrate the principles I am discussing. Look on the left-hand side. That is a normal response to light shining on the pupils. So on the top, we have a person looking straight ahead. I would estimate that in a normal person, this level of pupillary dilation means their pupils are about 5 millimeters. Now, light was shined on the left eye here. Do you see that the pupil is constricted? And while the light is being shined on the left eye, what is happening to the fellow eye? It is also constricting. Remember, the pupil constricts to light and both eyes work together. Now, the examiner swings the light over to the right eye. What happened? The pupil stays constricted and the pupil in the other eye matches it. Now, let's go over to the right-hand side, okay? Here, we have a pupil that has a problem, and we're going to work through this together. First, this person is looking at a distance, and their pupils are here about 4 millimeters, I would say, a little bit smaller than on this side, so 4 millimeter pupil. The examiner lights the left eye, it constricts, good, and the right eye constricts, also good. So the pupil constricts to light, and both eyes work together. Now the examiner swings the light to the right eye. The pupil does not constrict. That's abnormal. Pupil should constrict to light. This pupil dilates. That means there is a problem with this pupil. And because they work together, if this pupil is dilated, this one also stays dilated. Why does this pupil dilate with the light? It's dilating because either there's a problem with the iris. We know that's not the case because it was able to constrict before. It is not paralyzed, so the iris can work. So what else could be the problem? The problem could be that the optic nerve does not sense the light and doesn't tell the eye to constrict. Or the problem could be in the brain. The brain is not sensing the light in this eye for some reason, and therefore it is not telling the eye to constrict. When a pupil does not constrict to light, or the other pupil does not match it, there's a problem in the nervous system that needs to be assessed. Now that we have gotten the vital signs of the eye, we need to test the function of the vision. There are 4 major tests to do this. We assess the color vision, we assess the motility of the eyes, we assess the visual field or the peripheral vision of the patient, and we check whether there are any distortions in their vision using an Amsler grid. So let's talk first about the color vision. One of the most common ways to check the color vision is using Ishihara color plates. This is a list of plates that have numbers inside colored circles. The numbers are of a different color and the surrounding background is of a different color. And this can be used to assess color vision problems, and also if someone has damage to their optic nerve, their color vision will be affected. You will notice that in one of the subsequent lectures. There are multiple numbers and you check how many of these plates the patient can read correctly. You cover their left eye and do all of the plates with the right eye. Then you cover the right eye and do all of the plates with the left eye. The plates are in a book and you flip through the pages and see how well the patient can tell the numbers and how quickly they can read them. Sometimes the patient may be able to read the numbers on the color plate after some time, but you may notice that they are able to do it more quickly in one eye versus the other, which means there is some difference in the function of the two eyes. The next test is ocular motility. This is done typically with both eyes open. You have your finger in front of the patient in the center, and then you tell the patient to follow your finger and you have them look up, look down. Go back to the center, look right, look left. Go back to the center, look up and right, center, up and left, center, down and right, center, down and left, center. And you can see on the right hand side an image of what a person with normal ocular motility is able to do looking in all of those positions. The next test is the confrontation visual field. It is done one eye at a time. The reason it's called a confrontation visual field is because you are confronting the patient directly, you are checking their vision, and you're checking how wide the field of their vision is. You have them cover one eye at a time. So in the picture on this slide, the person is covering their left eye. You have the subject look at your face while you are sitting directly in front of them. Now you cover your own eye, which is directly opposite in front of them. So in this case, the person is covering their left eye. When you are sitting in front of them, your right eye is directly opposite, so you cover your own right eye. Now, with your other hand, you check their peripheral vision by putting up numbers with your finger. Put up 2 fingers, 1 finger, 3 fingers. You see if they can see as far to the periphery as you can see. If they are not able to see things in the periphery, you move your fingers in closer and see if they can see the numbers that you are putting up now. This way you can assess if a person has a problem in their peripheral vision. The last test of visual function is the Amsler grid. This test is also done one eye at a time. What you do is you have the patient cover one eye, so if they're looking with the right eye, they cover their left eye. You have them focus on the black dot right in the center of that grid. While they are focusing on that black dot, are any parts of this grid missing? Are any lines in this grid appearing wavy, again, while they are looking straight at that dot? If so, that means there is an area of the retina that is compromised, and that is something that will require further examination. This is an example of some of the abnormalities that people can see when they use the Amsler grid. They might see a dark spot in the grid, and this is an area where there might be some damage into the retina, or the lines may appear distorted and wavy. This means that there is some anatomical problem with the retina. This is just a quick note to let you know that oftentimes in an emergency setting, when someone's vision is affected, a good way to tell if the problem is with the optic nerve or with the retina is to use the Ishihara color plates and the Amsler grid. If the problem is with the optic nerve, the patient will not be able to see colors very well. If the problem with someone's vision is the retina, specifically the center of the retina called the macula, have them look at the Amsler grid. If they are noticing a dark spot or a missing spot or the lines are wavy, that means the problem is in the retina. Now let's get to the anatomic exam of the eye. First is the external exam. You are looking for three main things. Orbital symmetry. Is one eye above the other, or are the two eyes aligned horizontally? If one eye is below, that means there might be a mass or a tumor pushing on it. Next, you look at the eyelids. Are there any masses or lesions on the eyelids? Is there any drooping of the eyelids? Is there any blockage of the puncta? Remember, the puncta are what help drain the tears through the eyelids into the lacrimal sac and the lacrimal duct. And if a person has a blockage or an infection in that, it needs to be treated. Lastly, you look at the eyelashes. Are there any extra lashes? Are there any misdirected lashes? If someone has lashes that are curved inwards, they can scratch the cornea and bacteria can get into that scratch and cause an infection. The patient you see on the right here has a problem with their eyelids. Can you tell what it is? They have ptosis, or drooping of the left eyelid. As you can see on the right side, the eyelid goes above the pupil, and in the left side, the eyelid is going across the middle of the pupil. This could be causing some vision problems for this patient with respect to their ability to see from their left eye. The next exam is the anterior segment exam. Ideally, this takes place using a specialized instrument you see on the right called a slit lamp, which is essentially a large microscope that has the ability to manipulate a beam of light to make it bigger or smaller in order to be able to see the various structures of the eye. The slit lamp is an essential tool for an ophthalmologist to be able to examine the eye. This is an example of the different ways in which the slit beam can be used to illuminate the eye with different ways of manipulating the light to be able to pick up different problems. On the left-hand side, you see a wider beam that is focused on the sclera and the cornea. Could you pick up any problems in this eye that we see? Anything different that is not supposed to be there? Now let's look on the top right-hand side. This is diffuse illumination of the anterior segment using the slit lamp. What can you see using this form of illumination? And now look on the bottom right. This is a thin slit beam that is at an angle, and that thin slit beam at an angle is able to visualize multiple layers: the cornea, the iris, and the lens behind it. Can you see one pathology that is there in that bottom picture? Now let's go over what the abnormalities were. In the big picture on the left, there's a red star showing a scar running across this cornea. Also, this conjunctiva has brown pigmentation on it. This can be normal in people with darker skin, or this can be a sign of a precursor to melanoma. You have to assess the correct patient and see whether their skin color matches and whether there's a history of this in the family. In this picture, there is a vascularized mass on the iris, likely to be a tumor and has to be assessed. Here, the slit beam is able to illuminate a lens that is started to become cloudy. That is a cataract. The posterior segment, or the inside of the eye, is a little bit harder to examine. It requires having practiced this many times, and even then, it is best done on a patient whose pupils are dilated, and there are two ways to do it. The direct method uses this direct ophthalmoscope, and the indirect method uses a headlamp and a lens to help visualize the back of the eye. When you're looking inside the eye, you're looking at the vitreous body, which is the clear gel that fills up the inside of the eye. You're looking at the optic nerve in the back, and you're looking at the retina, which covers most of the inside of the eye, as well as the vessels along the retina. Direct ophthalmoscopy is falling out of favor because it provides a very, very small view, and it is very hard to do. On the right, you see an examiner using a direct ophthalmoscope to look inside a patient's eye. All they are able to see at any one time is a very, very small amount of the back of the eye. This is the whole area that you could see with indirect ophthalmoscopy, but this is all you can see with direct ophthalmoscopy. And so you have to use this mainly to look at a very small area, such as just the optic nerve. That is why this is primarily used by neurologists who want to look at a patient's optic nerve in the office. Indirect ophthalmoscopy is done by ophthalmologists. It uses a lens like this that is typically 20 diopters, 28 diopters, or 30 diopter lens, handheld, and then they wear a headlamp that sends light through the lens into the eye in order to be able to capture an image. And you can see through this lens just how much bigger area is able to be visualized. You can see the optic nerve, the macula, which is the center of the vision, and the center of that is the dark spot right there, and you see the vessels coming out of the optic nerve, and this is a healthy retina.